You are taking a picture of us? Wonderful. Wonderful. Yes.
Yes, sir. And tell people that we're starting outside as well.
It's always good to have, a little bit more people, in the audience.
On the stage.
When you reach this level, it's okay.
But you know the...
Thomas,
Zaczynamy, tak?
we have around 15 people.
Dobrze, ale to chodzą dalej ludzie. Good afternoon, everyone. I was going to give a few minutes for those who are coming, but I think people will be coming and going, so we'll have a very sort of soft start to this panel. But first and foremost, it gives me a tremendous pleasure to moderate a discussion panel about future-proofing Central Eastern European systems. It's very much in line with the theme of today's forum about future leaders. So we have current leaders talking about future. Starting with Dorica Dunn, who is the board member of EURODIS, the European Organization for Rare Diseases, for patient organization. Dorica will definitely give us fantastic perspective from the patient side, as well as the changing environment for the patients and how patients are included in decision-making processes. We have also Jakub Dvořáček, who probably needs no introduction, Deputy Minister of Health, very much responsible for what I believe Marcin Czech and him has been discussing a moment ago, an MCDA system in Czech Republic, one of the most exemplary systems that I believe currently exist in Europe. And another person whom you have probably already seen several times today at different panels, Marcin Czech, Professor Marcin Czech, former Deputy Minister of Health, who will definitely offer us Polish perspective to this very international Central European panel. We also have Bertalan Nemeth from the Syrian Institute in Hungary, health economist, but also someone who has authored 2 papers, in fact, together with Marcin and several other people, on patient inclusion in health technology assessment. So again, we'll be looking to learn a little bit more from your perspective as a health economist. And finally, last but not least, by any stretch of imagination, Tomáš Doležal, founder of IHETA, will definitely share with us some of the perspectives from across the region, as he's working with many stakeholders, both public and private, across all the countries that are included in Central Eastern Europe. So without further ado, before we start the panel itself, I wanted to give you a short introduction into the recent developments that are happening currently in Central Eastern Europe. Having talked to several people here today, I've actually glimpsed everyone saying that they are experiencing a region that is in a flux, that is really changing rapidly. In many cases, even leapfrogging solutions and innovations that exist in more developed countries like Western Europe, Czechia being one example. So without going into great detail, you can really see that the changes are occurring in 2 main areas. Either the reform of the HTA system, health technology assessment, as we are seeing with Poland, with Czechia, and ongoing Romanian development of HTA. And the second element of the big change is the inclusion of patients in decision-making processes. So these are the 2 pillars that clearly are being represented across our region. Less so, unfortunately, in places like Hungary and Slovakia, more so in places like Czechia and Romania, hopefully. Now, despite all those positive changes in the Central Eastern European region, we are still, majority of our countries are still lagging behind Western Europe and developed world when it comes to orphan diseases. So what you see on this slide, it probably requires a little bit of an explanation. On the left-hand side, left axis, is the percentage of EMA-approved rare disease medications that are reimbursed in these countries. So as you can see, places like Romania, Bulgaria, Hungary, Slovakia really only reimburse under 30%, so very, very small number. Now, what we are seeing is, and these are marked in green, Czechia and Slovenia are real outliers. In the recent IQVIA weight indicator, Czechia has jumped, I believe, 7 or 8 places, correct me if I'm wrong, really together with many of the Western European counterparts. Slovenia is another very interesting country. Pity we don't have a representative from Slovenia, but maybe, Tomáš, you can share some of your insights, or Bertalan, actually you do work with Slovenian counterpart Rok Hren. Maybe you can also tell us why Slovenia is so successful, being actually higher than majority of the countries that we associate with very equitable access to medication, such as Netherlands or England even. So only those 2 countries really are amongst the well-developed, equitable healthcare systems, and we are still lagging behind. Poland, as you can see, is sort of on the verge of a circle. So hopefully making this leap towards a better, more efficient, but also more equitable and sustainable system. Now, the reason why we are here is also to discuss the value of orphan medicinal products. Why are we not reimbursing something that is hugely valuable? The partner of this panel, KESI, has actually sponsored this particular study, that is an IQVIA KESI study, about the disease burden in about 24, I believe, rare diseases. What you see here is the cost burden on the patient and on the system with or without treatment. What is staggering, and I think this is so important for any policymaker to know and to reiterate, is that actually those diseases that are treated, rare diseases, with high-cost medication cost us less than when untreated or when treated only with supportive care. In some cases, as you can see with metabolic disease, this is as much as 51% delta difference. So it's huge health gains we are getting from actually introducing those treatments, which we, as you have seen on the previous slide, are not very good at yet. So I'll leave it at here. I think this is by way of introduction to the panel, and this sort of leads me to actually my first question to Tomáš Dolezal. I have mentioned, Tomáš, you work very much across the region, and of course the healthcare systems that we are seeing are still imperfect, but are tending towards equity, sustainability, quality. So out of those systems, you have glimpsed definitely the bad and the good. So the challenges that this region is facing when it comes to access to innovation, access to rare disease treatments, but also the key success factors. What makes countries like Slovenia succeed? What makes countries like Czechia make such a giant leap from being in the back of the European peloton to coming to the front? So why don't you share with us a few words of wisdom on challenges and enablers?
Thank you, Thomas. I'm not sure it will be a wisdom, but let's let's try. I think there's a lot of challenges and also opportunities, but I will try to touch at least 3 of them. I assume to be crucial for successful development of let's say orphan medicinal product specific pathway. First is the recognition that these products are different. They are not fitting to existing reimbursement schemes like drugs for cardiovascular, diabetic, etc., other diseases, because you need to address different judgment values and different needs and different aspects, like equity, solidarity, humanity, societal perspective, etc. So you have to create a specific framework which is dedicated to orphan medicines product. That's the first recognition, and we still do not see it in all the countries, and they are applying existing willingness to pay threshold to this product. It does not work. Simply, it does not work. So it's the first prerequisite is, let's say. The second one is also very important to stay aligned across the stakeholders, is to allow affordability of these products at the payer side, because these products for our countries and countries in the Eastern Europe are really costly per patient, and their prices are skyrocketing, and we have to allow to payers, to insurance funds to negotiate affordable prices. So we have to do a proper assessment of the medical added medical values. We have to allow risk-sharing scheme agreements, invisible prices, really to get as tight for companies as possible to allow to access to these products. And the third one, and it was very typical for Czechia case, was that you need to create, let's say, not only multi-criteria additional decision analytic framework, but you have to allow multi-stakeholder involvement environment, let's say. I remember that before the final law passed the parliament in Czechia, -4 years, started roundtables, discussion how to shape the system with the involvement of patient advocacy group, with the involvement of medical society, what's called payers, ministries, etc. So you need to share, raise the voice for everyone who will be involved in the future system. You cannot create it without all these stakeholders. So maybe these three ingredients seems to me as a key for developing the fit for purpose systems.
Fantastic, thank you so much. And in a way, you've referenced all those success factors, but they do boil down, if I may say so, to really orchestrated, fully endorsed policy. You spoke about changes within the system, but also the system itself needs to be aligned in order for those rare diseases to be recognized as unique and treated as such. That leads me to a question to Professor Czech, since I like reminding everyone that Professor Czech has been the author of the Polish medicines policy, the very first proper document listing the policies and frameworks that the Polish healthcare system still adheres to. So maybe from that point of view, I think Tomasz also mentioned something to do with policy, to do with rare disease policy specificity. So on the one hand, we have the overall medicines policy. On the other hand, we have a very specific rare disease plans that many countries are developing. And finally, there's a third layer that hopefully you can touch upon. We have the supranational layer, the European layer, the JCA, Joint Clinical Assessment, that is bound, well, will be impacting very heavily the area of rare diseases and oncology very, very soon. Could you comment on those three different levels of policy and what really needs to occur in order for rare diseases to be equitable for the patients?
Thank you for this question, and two remarks before I start. I only co-authored the policy, that's the first one. There was a whole team working and the involvement of many stakeholders, including all stakeholders in a public domain, was crucial in the process. Otherwise, it will be a document that is worthless. I mean, maybe not worthless, worth the paper. But this is one point. And the second one is not valid anymore. So now what we have is only a document that assesses to what extent the document was implemented, because it ended at 22 and there is no new one, unfortunately. Why unfortunately? Because we have a lot of new challenges which we need to address. For instance, gene therapies, advanced therapies, as such, gene and cell therapies, which were non-existent in the document that was prepared in 2017. Right. It is a strategic, it was a strategic project, because to reform the system, we needed to know the direction. But rare diseases and orphan medicinal products were part of this, this document and this study to some extent, or agreement, because it was an agreement and it was approved by the government. so that they are okay with the direction. And in this document, there was everything that was mentioned by Thomas. So that the drugs are unique, the rare diseases are unique, the orphan drugs are for selected populations, that we shouldn't expect such a strong evidence coming from clinical trials. Sometimes there are one-arm clinical trials only. That my favorite pharmacoeconomics is only partly applicable, because either you move the threshold up or you say the threshold is not needed. There is in the document, there is a suggestion of different approaches, including multi-criteria decision analysis, and that is why I'm so happy our two Czech colleagues also representing the Ministry of Health, which by the way is closer to here than the Warsaw one, as you can see, which I also regret that we cannot discuss with them. But as a result of implementation of this strategic document, in the proposal of reimbursement law, we have MCDA to be considered as a decision-making supportive tool to make the decisions of my colleagues now easier, because I think it contributed to opening a new pathway of granting reimbursement, for instance, in SMA for all treatment options and many other diseases, but with a lot of risks around. And we hope that MCDA would reduce these risks for the decision makers and allow them to make good decisions. It does not mean, and I would like to stress it, that we should reimburse all that is available in the system. We should reimburse the things that bring value to the patients. And let me remind you that we have only about 5% of treatments for rare diseases. So if it is so rare in the area of rare diseases, we should consider them profoundly, but based on the criteria that are repeatable, that are evidence-based, that include other stakeholders, that seriously include indirect costs, etc., etc. So that would be how I perceive it. And what we should do here in Poland, we should really look at what is the implementation, what are the caveats, what are the pitfalls, what are the successes of implementation of MCDA in Czech Republic to avoid mistakes and to implement something that really works, with your permission, of course.
No, I mean, that's obviously a tremendous insight, that we are not only talking about multi-stakeholder, but also multi-country approaches. And actually, that maybe you could comment also on this multi-country aspect, either pan-European or even just Central European.
Sorry, and I will keep it short as I can. So firstly, we are lucky in Europe because we have registration for orphan medicinal product at once in one place and applicable everywhere. So theoretically, you have this first level of access everywhere in Europe the same. If EMA says yes, then we can go for it. And joint clinical assessment for me is a huge opportunity of saving resources for not multiplying the same decision-making steps in every country if played well. If not played well, then we will have two barriers, one in Europe and the second one in our countries. So it needs to be played very wise. The game is very difficult. How to harmonize all these processes? I remind you that it concerns only clinical part. So it's not it was the threat of my boss at a certain point of time, that it would be an automatic decision of reimbursement on our markets, which is not true. We have our own cost effectiveness and our own budget impact analysis that is done in several countries, in Czech Republic separately, in Slovenia, which is the richest in the area and one of the smallest, independently, and in Austria independently, etc. So there is no threat of this kind. But I think this cooperation, but also some exchange about the ideas, for instance, what could be the mechanism of financing of advanced therapy in Czech Republic, in France, or in Hungary, is of a great value. So I would say joint clinical assessment, yes, if planned and implemented in a right harmonized manner, but also exchanging idea how to organize the rest. Maybe even one day realizing my dream of common negotiations, sub-regional ones, like we started the talks in V4 plus group in the past. So a lot of extremely interesting areas to jump into and to dive into in Europe, because it's the first time for last 20 years the changes in Europe are so advanced in the pharmaceutical market. The best times for experts to be a part of these changes. Thank you.
Thank you so much. I mean, you've mentioned something very important, that the JCA is not merely a clinical assessment, it's a platform that provides a structure for a structured way of sharing best practices across the countries. At least we have one unifying factor to some extent, and which could be used like this, if I understand correctly.
No, it's a joint clinical assessment. So clinical part is done together. Of course, it is done by one of the agencies and shared technically. Everybody uses that assessment, but the second part is about exchanging ideas and information, and maybe some mechanisms also within the system, how, for instance, finance, how to use risk-sharing agreements for for instance, advanced therapy or very expensive drugs in our countries, which will be, I would say, a different level, which is not the part of the European pharmaceutical package.
I'll hazard an additional point to this, that perhaps even going outside of Central Eastern Europe, was the organization or joint organization of HTA for rare diseases in the Nordic countries does tremendous job at both joint assessment, but also joint procurement, which you have referenced, joint negotiations. So maybe that's something that could also be transferable. But speaking of JCA, one of the very important elements of JCA is PICOs that countries need to generate. But PICOs, of course, as the very name suggests, has a P in it, the patient, the population. And as such, of course, of those multi-stakeholders that we have referenced, really the patient becomes critically important as a member, as a provider of information, provider of data, provider of insight. We are now beginning to speak of patient experts, and that actually leads me to the question to Dorika. You, as a patient expert, maybe you can also share with us how JCA from a patient perspective may work, but more broadly also, what challenges as patient at the European level in Romania you have had in order to be listened to, in order to be part of the decision-making processes, and what are the potential best practices, to Marcin's point, that we should transfer between countries if such practices exist. I believe Czechia has a great practice to share as well.
Yes, I'm sure Czechia has best practices to share, and we never forget that the recommendation for rare disease came from Czech in 2009, and now again the signal for a new European Action Plan came from Czech Republic. So I think we all recognize the way Czech Republic is working in the field of rare diseases, and thank you very much for your involvement. And as regarding the involvement of patient organization, I think that the new innovation is collaboration. So Patients are the only stakeholders that can facilitate the communication between all the stakeholders and bring together all at the same table and discuss the challenges and the opportunities. And we have seen that there are several challenges, and I would add that in Central and Eastern European countries, we have more challenges. For instance, we don't have national registries, and not all the member states are recognizing the orphan codes. Until we will recognize the orphan codes, we will not find the patients, because we don't have the rare disease patients. We have only about 500 rare disease that are in ICD-10 that we are using, for instance, in Romania. So in order to achieve and to have a share value-based care in Central and Eastern European countries, we have to dare to dream that we will transform the healthcare system into something that is not only answering to symptoms, but will answer and will provide quality of care for patients and best outcomes for patients. And this is something that can be achieved only through education and communication, information of all stakeholders, and bringing all to the same table and training them. So if we learn how to listen the patient needs and answer to these needs, we can design healthcare services according to these needs. Otherwise, we can't. And this is how we started in Romania, for instance. We had a lot of challenges, mainly because we are living near the border with Hungary. We are close to Budapest, not to Bucharest. So for me, as a coordinator of the National Alliance for Rare Disease, it was very difficult to maintain the connection with the policymakers and to make the National Plan for Rare Disease a reality. But we could do this only with the support also of the professionals, and we involved professionals. I think we have a very close relationship with all the professional centers of expertise in Romania and other stakeholders, pharmaceutical industry, and we succeeded to bring all to the same table. And now we have a new national plan approved. It is in the National Strategy for Health, and for the first time it is also with budget allocated. I think there are a lot of best practice examples, starting with Eurordis, that is training the patients to become expert patients. It started a long time ago with the summer school and winter school for rare disease. Now we have the Open Academy, where we try to train patients to become EPAGs and represent the voice of the patients inside of the European reference networks, because now the European reference networks are the way the patients can be treated not only at national level, but at European level. And connecting all the professionals, bringing them and making them to communicate cases, it's very important also on CPMS at European level. Other best practices, for instance, we have created a center in Romania called Nowe Center. Our center is accredited as a center of expertise, and it is part of European Reference Network ITACA since the very beginning. So I think this is the only center coordinated by a patient organization, and it's from Romania. So things are possible if you dedicate a lot of work, of course. Of course, we are lagging behind with the access to treatment and the days that the patients are waiting until an orphan drug is approved by EMA and it became really available to the patient. That's something that is not all in our hand, but we are insisting, and in our advocacy, to give another example of way of working, for the last 12 years, we are organizing the Rare Disease School for Journalists, because they become our supporters and could support our advocacy work at national level. I think patients have to be involved from the very beginning, from the diagnosis, And throughout the healthcare pathway, at all stages, the patients should be involved and give feedback and help designing services that are answering to the needs of the patient. This is how the patient can be involved, and they can be involved only with adequate training and education and collaboration with all the stakeholders.
Thank you so much. And it's very clear that the patient is absolutely critical at the very beginning of, for instance, assessing orphan medicinal products at EMA level, which, by the way, only in 2022 issued the policy framework on how to involve patients and consumers in the decision-making process. But we are speaking about EMA, so we are talking about risk-benefit analysis, in which case, who is better to say what trade-off between risks and benefits they're willing to make other than patients?
Yeah. I think patients are very important to be part of these committees too. And we have patients that are representing rare disease in EMA in different committees for many years at Eurordis. And also patient advocates are invited to give feedback when a new treatment is on the market. For instance, myself, I was several times participating in these meetings. So I think the feedback from the patients is very important, and also in the decision-making process. So being involved in the National Committee for Rare Disease, for instance, at national level, to monitor the implementation of National Plan for Rare Disease, or in different working groups, like now we have a working group on off-label treatments. I think it's very important for all the stakeholders, even if sometimes some of the policymakers do not recognize this need. I think it's very important, and finally, the healthcare system will be designed in a better way for everybody, and more efficient for everybody.
In fact, that sort of links very nicely to the two papers that I have mentioned Bertrand has co-authored, which actually does speak about not about a specific pivotal moment in the life cycle of any medication, which is HTA, and how patients can be involved in there. We will get to Jakub, of course, and Tomáš to describe the Czech system. We are keeping that for last, because that's the exciting bit. But yours also is an exciting article in that it lists very clearly not only why we should involve the patients, which Dorica has so eloquently already put, but also who to involve at what levels of decision-making process, when and how. So maybe you can give us that who, when, and how, a bit of a close-up for the HTA-specific involvement of patients.
Yes, thank you very much. You know, I also agree with talking about the Czech system at the very end, because, you know, at dinner time, the dessert always comes at the end as well, and probably that's going to be the sweetest part that we're going to be talking about. I'm saying that because our papers, I'm saying ours because it was, of course, born out of a collaboration, including our dear friend Marcin, several other HTA and payer experts, as well as, of course, patient experts, including Eurordis representatives. So we looked at actually the barriers of why adequate patient representation in Central and Eastern decision-making, why is it not happening yet? Because the seeds are already there, quite many stakeholders agreed upon it, that the opportunity presents itself, yet we still need to overcome certain barriers. So the first half of our research focused on that. We did it through the framework of a Horizon 2020 EU-sponsored project called HTX. And basically, we identified 22 concrete barriers which prevent this adequate utilization of the knowledge that the patients have on their condition. And, you know, of course, that's only half of the work, identifying the problem. The other half is how to overcome it. How can we draw up solutions to overcome those barriers? This was what the second part was actually about. And the group came up with 12 of these. Now, not surprisingly, a lot of them relate back to the barriers directly. So, for example, a barrier was listed, and I'm very happy that Danica spoke before me because what I'm saying rhymes very well to her experience. One barrier was listed, noting that sometimes the people representing the patients, they don't have the adequate level of knowledge on certain topics so that they can make valuable contributions, which immediately drives us to, okay, how can we overcome it? Educational program, just as Danica was talking about, for example, what Eurordis is doing or certain other organizations are doing. So once again, it's one thing that we have a situation currently which is not perfect, let's be honest. But, why should we just sit down and relax? We can overcome those. So, like I said, we found 12 of those. I'm not going to go through each and every one because we would be here all day, but just to highlight a few of them. This education is absolutely important, but it goes both ways. So not only the patients require to know how the systems work, how the processes work, but also our group noted that oftentimes the people sitting in the chairs of the decision makers, they don't always realize what benefits the patient voice can bring to them. So that's education going the other way. Also, certain, I would say, practical things were listed. For example, how in many countries, it's very hard to find who is the right person to speak about a certain disease. Why cannot we have an organized system where if a decision maker, let's say, wants to have a discussion on the reimbursement of an orphan drug or a diabetic drug, etc., the decision maker should know which patient organization or which patient representative, patient expert to turn to. These processes need to be formalized. Also, several countries listed that, it's such a big problem. Bertalan, we have an HTA guideline. Currently, there's no place for the patient voice in it. What can be the solution? Revise the guideline. Actually, even outside of this topic, it is advisable to revise your HTA guidelines every 3 or 5 years. Why cannot they put in a section on this, on how and who should take into account the patient's perspective? And also, since everything is connecting back to organization, if there's a dedicated person from the patient side, there should be, of course, a dedicated person from the HTA side, from the payer side, whose job is to connect to these organizations and take their feedback in various ways possible. And finally, if I were to group in like a couple of our recommendations, if we are thinking about systems that will hopefully run continuously, we need to organize continuous funding for both sides again, because it's not only the patient side, it's also the decision maker side. There should be some funds allocated to taking in the feedback coming from patients, as well as, and this was quite often reported unfortunately, the patient organizations, they need to have a stable and transparent funding as well to properly function and to properly adhere to this future role, hopefully.
Fantastic. Thank you so much. And you've touched upon so many of the aspects, both of the positive and the negative, the challenges that we are facing. But ultimately, if I understand correctly, also, this really boils down to a sort of a 4D system. Define, diagnose, define, diagnose, define, design, deploy, in a sense that you first need to diagnose the situation of your current landscape of patient organizations, to know whom to talk to. Then you need to define precisely, you've mentioned both the funding, but also the governance, so how those organizations can be governed, how they are funded. Then you really design the system from scratch. As you said, the HTA perhaps needs to be revised every 3-4 years, so that's the design stage. And of course, deployment stage is what we are going to hear about very, very shortly from Jakub. So I think Czechia definitely followed very clearly those steps, really, really pragmatically and really step-by-step process to achieve a system which I will not describe. I think the best if we hear it from Jakub exactly how it works. But one curious element of that system that I mentioned up front before we move to the story of how you develop the patient inclusion in HTA, something that very often shocks people is that the patients involved in voting in HTA for a specific medication are not the patients with the disease that is being discussed, that is being assessed. So I'll leave it at that because that's the controversial part or the shocking part, but I'll let you tell the story as it is from the beginning, Jakub.
Thomas, thank you. And yeah, from where to start, maybe the disclaimer at the beginning, which will maybe gives you the better picture, you know, why it was possible. I could say, you know, it's how do people, you know, move between the industry and government in the Czech Republic. I believe it's quite specific. Trust between the industry, patient group, medical scientific societies, and the governmental officials. It's quite normal. For example, myself, I was heading the Association of Innovative Firms of Industry for 12 years. Now I'm the deputy minister. My colleague, who was the deputy minister, he's now heading the Association of Generic Industry. It's quite normal to move it, you know, in the Czech Republic between two different spaces, I would say. It shows you that the trust which is built there is quite unique in Europe. And what I would like to highlight it at the beginning, one of the reasons we success, you know, with that story, is that we get the support from the industry at the beginning, I have to say. To ensure, you know, that there is a continuous funding for education and development of the patient groups, it was one of my key tasks, you know, in the association. And this is the reason why we already have now the patient groups who knows the HTA, who are involved in that, who are trained, and who are quite a equal partner, for example, to medical scientific societies representatives. And it took more than 10 years. 10 years of work, of an investment. And I have to say one of my toughest tasks was to ensure that this continuous funding from the industry goes to the development of the patient sector and medical scientific area sector. And yes, the result is that at the end we were able to deploy. And maybe, you know, just very briefly to cover, you know, how the system works and what is, let's say, the specifics. And I believe that Tomáš then can build on that. He was also the part, you know, of this process from early beginning. Yes, we have at the beginning not just the company who is applying, but also the patient group and medical scientific society. Those who are involved, you know, in the certain disease. So we can get, you know, quite a nice view how the disease really influences the life of the patient, the family. So we can include also those social impacts, you know, of the treatment and to have a really inclusion of all those parameters. Then what I would like to also highlight is the time. You have to be fast, but not too fast. You have to give the special time between the first evaluation and then the decision for the negotiation. And I believe this is also quite a unique opportunity that we are creating the space between these two phases of the process for the company, for marketing authorization holder to come, to negotiate with payer, to increase the chances, you know, for final approval. That's the time between those two steps. And then on the end of the process, who is really, let's say, making this decision, the patient group again, but not the one, you know, who is involved at the treatment. But let's say from the pool of the patient organizations or patient representatives who get the education and training, who are, let's say, certified to be, let's say, part of this decision-making process, who have a, let's say, clarity, you know, in the conflict of interest again. And the same it is, you know, for the medical scientific societies representatives. They have to really, you know, declare the conflict of interest. And all of these things, you know, works together with the ministry representatives and the payer representatives, gives you the balance on how the decision is at the end done. And yes, we moved quite far, you know, with the access to rare disease treatment. And I believe we are coming close to let's say, a certain barrier which each and every certain Eastern European country has. And it's the size of the population, the size of the market, and of course, you know, the financial issues of the treatment. And I have to say, you know, that now it's also the step, you know, on the side of the industry, because I believe that to ensure, you know, it will fly in the future, doesn't matter what kind of review and system we will use, in any country, is, that we will get chance to negotiate. And what we see now is, let's say, the really ultra-rare disease treatment coming to systems. And very often it's quite difficult, for companies which are not always, those, let's say, traditional pharmaceutical companies. More and more of them are, let's say, mid-size or smaller biopharmaceutical companies. And the problem is that the capacity to really ensure, that they have enough to come and to share and negotiate the data and to find, the final agreement with the payers. In all of those 27 countries, it's more and more complex and complicated. So I'm coming back to what was said, from the view of the patient organization and Eurodis, that we will need to continue to build, the network of the centers, because I don't want to have every center in the Czech Republic. It doesn't make sense. It's enough, to have it, in neighboring countries, 2 or 3 centers in Europe, then to use the capacities, which are available. And of course, every patient wants to be treated with the medical professionals who, let's say, get real experience with the patient, not starting from the scratch again and again. So we will need the Europe, we will need the joint approach, we will need the European plan for the rare disease, and also the funding, which will not fund the treatment itself. It's on the states, on the countries, but this capacity to have, the centralized care.
Thank you so much. I mean, this is a real tour de force of what has been the case. I like likening optimal healthcare systems to the Rubik's Cube, i.e., you cannot just get one side right. You have to get all the sides working together. So the efficiency, the quality, the sustainability, the equity, every aspect that you have mentioned. And I think, Dorica, to quote you, the real innovation is the collaboration. So I think we are coming back to the same point over and over again, that collaboration not only between different stakeholders in a given country, but between countries, exchange of best practices is critical. And as you have just mentioned, sometimes just because the size isn't there doesn't mean we have to forego innovation. It's just about collaborating with the others, having, for instance, a center of excellence in Poland serving Slovakia and vice versa. So this is sort of the beautiful image of perfection to which we're all tending. I know we are coming, sadly, to close to an end of this panel, but before we summarize, I yield the floor to you guys again to summarize and give us maybe a few words of wisdom, few words of recommendation. Perhaps we can open the floor to the room if there are any specific questions. I mean, we have such a tremendous amount of experience and insight and perspective. I'm not sure whether you have any questions specific to any of the panelists or to the panel at large. Anyone? I can see at the very back, Adrian.
So I know for the start phase, for the evaluation phase, it needs to be an organization which is already involved, and it's a real patient organization. So it's maintained by patients. It's involving the patients, in their process. It's also about how they are registered. Of course, there are formal steps, which needs to be fulfilled. Sometimes, I mean, in ultra rare areas where you do not have the patient group, then it's the national Eurodis organization, Czech Association for Rare Disease, who is, let's say, providing those information on behalf of that patient group, or let's say the not organized group of patients. And then, for the decision-making process, it's a pool which is, let's say, regularly, involving more and more patient organizations. It's more about the people than the organization, because those people really have to have this experience and expertise to be able to read the files, which comes from our regulatory agency, who pass the trainings, at the HTA. And of course, what we do the review of their conflict of interest to ensure, that they are really representing the patient voice, not the voice of industry. Of course, it's necessary. And we carefully built the process, how to create this pool of experts and how to review them. And I have to say, this is one of the key aspects to succeed with the whole let's say, attempt to have the patients involved. On the other hand, I have to also say that the, let's say, more complex problem with the conflict of interest is, let's say, within the experts. Very often those who are representing the medical scientific area, because of course, especially in the area of rare diseases, to find the experts who are somehow, let's say, who understand the area. At the same time, they are not involved, for example, in the concrete clinical trial or let's say some advisory board for that kind of disease. It's not easy. So, what was decided or what we agreed is that the conflict of interest is not that the medical professional or the patient expert works, for the industry, but that it's not involved in this specific concrete treatment or, let's say, disease. So it helps a lot, to have of that balanced representation.
Thomas, would you like to?
Yeah, maybe one comment to that. It's really interesting to see because everyone knew at the very beginning that we have to be very focused on the education of patient groups, and it started through EPO and then by specific HTA education, etc. And looking back, that we a bit omitted to education to medical professional and maybe payers representatives about how these HTA processes, value judgments works, and now we see the fruits that they are not so prepared for the MCDA discussions and value judgments, because this is the weakest part. You say it sounds great to organize MCDA, but there are a lot of risks, and you have to be sure that people are really responsible for what they are saying, what they are proposing, and what they are voting for. And this is interesting to see that even as the process is divided into two parts, assessment and appraisal, they are totally at different sides of the wall. And for the same representatives of the insurance company, the representative of the same insurance company has the totally opposite standings in the appraisal part according to assessment part. So this is really devil is in the detail for this organization of these things, and you have to focus on education of all stakeholder groups together. That's maybe one of the experience we had with too much focusing on patients and omitting the other stakeholders.
Absolutely. Marcin.
Yeah, we were trying to approach MCDA from different angles in Poland, and for instance, there were like a couple of PhD theses, including one on using EVIDEM framework. And it turned out after 4 or 5 years of work that it's not an ideal model for decision-making process in the country. So that despite we went through all this process, we asked specialists in, I guess, 11 or 12 countries. It turned out that we are landing nowhere, that the tool is wrong. Then we had a very interesting attempt with Paprika. Joanna, who was involved, who is among the audience, can confirm that, where all HTA companies, which usually compete with each other, together they performed the study on MCDA and the weights in MCDA criteria. And there were a very long list of extremely interesting discoveries. Like, for instance, we intuitively thought that children would be privileged in their views, and they weren't. Am I right? It was very surprising. And so we moved a little bit closer to the framework that can be applicable for the decision-making process. Still, Ministry of Health didn't like it. They say, oh no, you want to have reimburse everything, oh it's too weak, and what do we need it for? We make decisions anyway, we are violating our threshold cutoff point, but we give positive decisions, you gave the first, now we give, so what do we need it for? But I have I would like to echo what you said. It's extremely difficult to make people understand what it is about. And you have a comment, you grab your mic.
It only took 10 years, right, in Czechia?
I did. Yep. I mean, all what you mentioned, it is definitely important. Same, Tomasz. But what I have to say, the experience we have it, I mean, from those 2 years when we are running now this process, I would say 95% of all the reviews we did finish it anyway, with the agreement between the payer and the marketing authorization holder. So at the end, the decision is quite easy. Because, if you already create the environment, which gives the data to the side who is reimbursing, and you give them the time between those two steps, and as Thomas said, all those processes are quite divided, then they are coming to the committee, to get this decision already with agreement. So it's not about, to do some difficult review. If the payers are already, let's say, in line, with what the marketing authorization holder is proposing, and we send a clear signal. If there will be the agreement, it will be much easier to pass through. And I have to say that's really working well. And this is one of the quite important, steps to create this environment.
Absolutely. Sad to say we are at the end of time, but I really would like to stretch a little bit our presence here and allow each one of our panelists to say a couple of final words just as a summary. Unless, of course, I think Bertrand, you had a comment on the specific question, right?
Yeah, but I can merge it into making my final statement.
Perfect.
Okay, so Tomasz, our dear friend, he talked about the who, the what, the where, the how. I want to emphasize the why. Now, why is the involvement of patients in decision-making important? And, I know when I previously spoke, it was a little bit technical because I was reporting on the research that we did. Now I'm going to tell you a story, actual story which transformed my view on things. You see, I was working at my country's HTA office, and during one event I met a lady who had a husband with a certain condition, and the husband's condition required them to travel to the country's capital 3 times every week. So you can imagine, like in real life, what burden does that make you in your everyday life. However, a couple of years later, a new formulation of the same drug came to the market. It was sold by the same company, roughly the price was the same, etc. Just the dosing formulation was different. And now it could be administered by the patients alone, without the need to travel to the clinic in the capital. And this is where the patient voice gets really important, because if you are just looking at things from a purely technical way, for sure you can mention it. Like it would have ended up in the HTA report among dozens and dozens of pages. But for them, this was like a life-changing development, because they wanted to travel the world. And this development has allowed them to travel the world, go to Caribbean islands and what so on. And if you don't contact the patients, even if you are trying to do your best job you can as an HTA expert, you're gonna miss these very important aspects. So to me, there are 2 morals of this story. A, this is why you need to hear the patient voice if you're an HTA expert or a payer expert. And 2, this is why we need to take into account other aspects. And this rhymes very well with the colleagues' discussion on MCDA.
Fantastic. What I also hearing is a denial of the common misconception that involving patients in decision-making process is costly, meaning that patient will always vote for the most expensive, the newest treatment, which is precisely the opposite in your experience, right? So again, I know I'm stretching time and space already, but just 1 minute each, and we are finishing. I promise. Tomasz, maybe Dorica. We haven't heard from you. Maybe you can say just a couple of words of summary or recommendation to us, to policymakers.
Because I was talking about who to be involved, and I mentioned patients and also professionals and policymakers. I forgot about the parents, and I think parents and caregivers have to be involved in this process, and at all stages, as I said, on the patient pathway. Also, we don't have to forget that patients with rare disease need, besides treatment, they need also social services, and we have to think how to provide integrated care for patients with rare diseases at European level, because also in Central and Eastern Europe, because sometimes there is no communication between ministries and there is no collaboration. So we need to create frameworks to provide real integrated care, not only to speak about it.
I'm very happy that you've mentioned integration, because it's one of the axes of value-based healthcare. One is outcomes control, the other one is care integration. So another topic that we could probably spend a whole hour on. Tomasz, closing words.
Yeah, I will be very brief. If I should environment of all stakeholders with the vision how to change the system, because the work is never done. We can see it in Czechia. There is a lot of problem we have to cultivate and create, and you have to have this ecosystem independent on political cycles, especially in our countries where ministries of health have so short lifetimes. So this is I think most important, and I think Jakub also stressed that point.
Fantastic. Well, that was very succinct. Thank you. Jakub, any more insight you can offer? Any final words you can add? And maybe they'll be heard in Warsaw.
Very fast. We had a very interesting conference in Prague last week, GlobSec, about security. Also the small part about the healthcare. What was presented there, it was quite a nice slide, which showed the correlation between the life of the minister and I would say of course in the political role, and how strategically country approach the healthcare. And if you take our region, the usual life cycle for the Minister of Health is a year or a little bit more. So it's obvious that our region is, from the strategic and planning perspective, quite not in the stage we should be. And the last things to mention it, and I believe it's also what we discussing with Rodis, with Jan Lekam, and people in the Brussels. We are now reaching the step or stage, where we should or have to somehow focus, how to react jointly in the EU, especially in the ultra rare disease area. If we have 1 or 2 centers in Europe to provide the care, then I really feel that the negotiation is supposed to come jointly, and we should have a joint reimbursement for those kind of therapies which are dedicated to such a small group of patients.
Fantastic. Marcin, this is the voice that needs to be heard as